Let me just say, I just came from a science sessions this morning in the educational part of the RSNA on spectral and dual energy CT, and it was so full that they had actually to open the doors and put more chairs outside and a live screen transmission. So that is really something that tells you that this is really slowly impacting radiology, and not only the academia, but also it's getting out to practical day use. And photon counting that I will target, especially in the second part, is of course the future of all this. Okay, just a few words on the recap of the basics, just a few slides to get you on the same page. X-ray computed tomography, we take projections, Lambert-Beer law, and then we reconstruct essentially the 3D distribution of the X-ray attenuation coefficient, and this is in clinical day routine converted to these Hounsfield units because these are more easy to handle from a practical point of view. In this attenuation coefficient, from the basic physics point of view, we actually have two interactions. Is the photo effect and the Compton scattering. The photo effect is basically when the X-ray photon gets absorbed, and this creates attenuation, and the Compton scattering is also attenuating by actually deviating in an inelastic scattering process this photon. And the total attenuation in the energy range where we are using in medical imaging between 50 and probably 120, 140 keV is essentially a combination of these two effects. So the really interesting thing is now that this photo and Compton effect have a different energy dependency, and this is really the basis for all this dual energy work and for this material decomposition what we do today. And if we, for example, look at these two plots, this is aluminum and iron on the right, and there's the attenuation coefficient as a function of energy plotted, and you see that the total curve might look like this, but you have the different contributions. This is the photo contribution, this is the Compton effect, and the Compton is relatively flat in this energy region, and the Compton is actually falls off, the photo falls off very quickly. Now we express this now as a combination of these two, and the really interesting thing here is now if you look at this crossing point between the photo and Compton, you see that there's a little bit to the left here for material with a lower atomic number, aluminum in this case, than for iron here on the right. And this now gives you essentially the possibility, if you would do two energy measurements at two different points here, then you would see a large difference here and a small difference here, and this actually helps you to solve this little equation and actually get the photo and Compton and differentiate between these two materials. So this is the super basics of how we do dual energy spectral imaging in the clinical practice today. By now, in daily routine, there are a couple of concepts, and these three are the most prominent ones. It started about 10 years ago with the brute force approach, I would say. Siemens put two sources, two detectors in one gantry, and then of course you can drive them at different acceleration voltages and get two different mean energy spectra, okay? A few years later, GE came out with a rapid KVP switching system where you would actually switch back and forth really quickly between two acceleration voltages and then also get two effective energy measurements for these two projections. Dual layer detector is probably the latest addition to this family. It came out from Philips, and it does actually the spectral separation on the detector by using two layers, and you can easily now imagine that the upper layer here would predominantly absorb more the lower energy photons, whereas the lower layer would actually more get the higher energy part because it's essentially pre-filtrated by the upper layer. Okay. There are more things like the twin beam dual energy system, a few other variants that I'm not touching here, but these things are all in daily routine use and actually are quite helpful to show you a couple of clinical cases why this makes sense. So what we get out if we do our magic with these two energies is instead of a conventional CT scan, this is now an abdominal scan here. You chose the liver. Basically, it's a contrast enhanced scan, and what you can now do is you can convert these two energy bins in photo and Compton. This is one basis material set, clinically not so super relevant, but you can then also transform into a different basis set. And something that is actually used very often is a basis set that shows the iodine only, so it's the iodine image only, and all the rest basically. This is then called virtual non-contrast, because it would be like a native CT scan without contrast agent, but it has been actually taken out by this computation from these two energies. So this is a very common representation of such a dual energy data set in the clinical system. You can also do something that is called monoenergetic imaging, and that essentially is a fusion, a virtual monoenergetic fusion using these two component photo effect contributions that we have separated before. And you can compute this back because you know the different energy dependencies at either low or either high energy. And the low one would, for example, boost the iodine contrast heavily because iodine has a very steep photo effect and is actually very enhanced at low energies, and at higher energies, I'll show you a case later, it would be very useful for artifact reduction, for example. And the last thing that is in use quite often is the C effective. So this is essentially the ratio of photon Compton and is the effective atomic number that you observe in this pixel. Okay, a few clinical examples. I brought 7, I think, today here. Using dual energy state of the art today, we have later more for the future photon counting, but one basic thing is a case that uses now this virtual non-contrast and iodine separation. And I showed this also yesterday. It's two patients here, a head scan. And these are two patients that underwent thrombectomy, so an intervention in the brain. So after stroke, you go in with an interventional procedure and you try to fix the problem and so on. And then 6 hours later, you do a control scan, a native CT control scan. And what you very often see then is these density enhancements here. And the big question now is that just a remaining contrast agent that has been used during the intervention before, then it's all fine because it will just dissolve itself after a while, okay? Or is it actually a new fresh bleeding that leads to more density because there's blood and so on, and then you actually have a problem, you have to open up again and then do it again. So, and if you now do dual energy and you separate into the virtual non-enhanced, the non-contrast and the iodine, you see that in this case up here there's no density left, so that was actually iodine. Everything's fine, it shows up in this iodine overlay map actually, and here it does not go away, so that means this is actually new water-like or blood-like density, and there you actually have to go in and do this procedure again. And you can actually confirm that by doing a T2 star MRI image where blood would actually show up in negative contrast, quite dark. That's a cumbersome procedure, so usually you would like to have a fast scanning procedure and answers with. So that's one very common thing. Interesting is also that's the same thing. Again, a patient after such an intervention, okay, and everything actually looks fine in the conventional image. But now you do this separation in virtual non-contrast and iodine, not shown here, and you suddenly see there is actually a density loss here. So actually there was iodine in this conventional scan overlaying this density so that you couldn't find anything or see anything. That actually is now a stroke area, and this can be ischemia, and you see this in the diffusion wave imaging protocol from MRI quite well. So it also helps to be more precise in the diagnosis in this case. So this VNC iodine case. Then using, for example, these mono-A cases that I showed before, that is a patient with a renal cell carcinoma, and he was there to figure out if he had any lesions also in the pancreas. And if you actually look very closely, you can see here something that shouldn't be there in the conventional image. But actually, if you look a bit more closely in the mono A40 image, you actually see also down here another lesion that is pretty impossible to see in the actually slipped in the normal conventional scan. And this is because the mono E40 artificially boosts through the enhanced photo effect the iodine signal So this is actually really helpful in this case. Another case is now the high energies. So the high energies are helpful when you are dealing with artifacts. Artifacts due to metal implants, you have in the teeth, in the hip, or even in the spine. So this is a patient that had some screws, neurosurgery to fix the spine, and you see that this always causes heavy streaking artifacts in the reconstruction. Now in mono E40 they are still there, but you can actually remove some of them, and now you get access to, for example, this area, and this is the aorta, filled with iodine, and you can actually also have a look at these aortocaval lymph nodes, which are very important from an oncological perspective, because if there would be something wrong, that would be indication that this cancer has spread and so on. And in the conventional CT image, you really have these problems of the overlying streaking due to these problems. Probably another case here. This is a patient where it shows that the C effective is also quite useful in terms of diagnosis. A patient that actually had an ileus, so some blockage in the lower intestines, so in the lower bowel, and the task of the radiologist is actually to figure out where in here is something obstructing the passage. And in this case, it was actually very difficult, but based on the C effective, it's actually quite jumps at you. There's something here that has a different color than all the rest in here, a color that actually is very close to the color of the adipose tissue around. So this is a gallstone with lots of lipid-rich gallstone, and that could be removed, and then actually it's all fine. And a final case where this, which I would classify as some kind of a mixed case, is this. You know DEXA probably, bone mineral density measurements. These are routinely done for figuring out osteoporosis or fracture risks or so on. Now, when you have two energies or a spectral detector, you can then, of course, also do this at once. And this is shown here in a little test experiment that patients that we did actually. This is a normal conventional image. Then you separate again into the photo effect and the Compton effect here, and then you can actually convert this into a bone mineral density map. This is what any DEXA scanner does, but if you now have a conventional also dual energy CT system or a photon counting detector, you could do this also immediately. And as is well known, this appetite bone mineral density actually is correlated to the fracture risk that you have. So you see more enhanced fracture risk in these osteoporotic patients than in the healthy patients. Okay, these are just a few cases out of the present state-of-the-art use of spectral, meaning dual energy clinical applications. Now, if we would have more energies, then of course we also have more possibilities. And this is now where photon counting comes into play. Photon counting, just as a little startup here, is actually in some sense a spin-off from high energy physics. We've been using that for a long time. For example, at the inner part of the Atlas and CMS detectors at CERN. So these are silicon tracker detectors that are there to track the trajectories of high energy particles, and these are actually hybrid pixel detectors which have a sensor layer and an ASIC below, and this is exactly what the photon counting detectors actually look pretty much today. So in the little more close up, it would look like this. So we have a semiconductor sensor layer to stop the high energy X-ray photons. You convert that into electron hole pairs. So it's a close up here, electron hole pairs. We put a bias voltage here, and then we actually get the charge through some bump bonds down to the ASIC here below. And then in the ASIC we can add whatever we like, and what we usually do is we add preamplifiers, pulse shapers and so on, and then we can actually throw them into different counters, so into different bins, and actually sort them also according to the energies. And it just depends on the ASIC here how many bins you then would actually like to have. But in principle, you have now the freedom to have a full color detection without these workarounds of KVP switching or two sources or so on. Yeah, these detectors, I alluded on that a bit more yesterday, but in summary, these detectors have about three important advantages. They have more energy bins to start with, because you can do 3, 4, 5, as many as you actually like. They have typically a higher resolution than conventional CT detectors, because the pixelated structure here is typically smaller and easier to make than present-day clinical photodiode scintillator-based detectors. And they have no electronic noise, because you count them or you don't count them, and you have no electronic noise below. In a conventional detector, you have the scintillator photodiode, and the photodiode will always have some electronic noise contribution, which can make life different. Yeah, I can show you some review of a few recent preclinical and clinical results. There are a few systems out there already, prototypes, no commercial products yet. For example, Siemens built 2 systems, installed one at the Mayo Clinic and one in Heidelberg. Philips built another photon counting prototype, installed that in Lyon, for example. And they have been used to figure out where this actually might actually help in clinical applications. So one thing is that you, instead of splitting a conventional image now into 2 energies, like the dual energy systems, you can do more. And you can do, for example, a virtual non-contrast. You can separate iodine that was put in these vials here, and gold as a second contrast agent that was put in these vials, and you can do colorful fusion images. But in principle, you can separate now as many material basis sets as bins you have in your detector. And that allows for a few creative ideas in terms of how one might be able to use more contrast agents. And this is what I want to tell you as first examples. Clinical potential of photon counting is now to use several of these contrast agents in one go, and then probably have more examples. And one thing to start with is this. You probably know colonoscopy. To figure out whether you might have cancer in the colon is actually suggested to do this as a preventional thing. You can also do this CT-based, because some people don't like this very much. Yeah? In CT, you can then tag, for example, the inner part of the stool by drinking a contrast agent. That's fine. Then you can subtract off, but then you typically see holes here outside. Yeah? And then the question is this now a lesion or a cyst that does not take up contrast agent? So what you can imagine doing is also injecting gadolinium intravenously. And then this gadolinium would show up in lesions that are metabolically active and that have a good vascularization. And this lesion is then something that would be critical, would have to be taken out. But this one that we mimic with some bit of plastic addition here, that would not be critical. So in that way, you could do CT-based colonography with injection of multiple contrast and separating this in one go with a spectral photon counting detector. Another case that is clinically potentially very interesting is this. What is done in advanced clinical scanning protocols often, for example in the liver, is something that is called a multi-phase liver scan. So what you actually do is you typically inject, you do a native CT scan here, you inject a contrast agent, then you wait for a few seconds to catch a very early arterial scan, and then a little later to get a second pass, a portal venous scan. And the reason why you do is in the liver is to characterize different lesions. So this here's a liver, and here's something that shouldn't be there. And these multi-phase liver scans allow you now to separate pathologic from non-pathologic cysts or HCCs or tumors or so on, because typically these differ in the way how they enhance in an early phase the contrast agent in the late phase. And yeah, the problem of conventional strategy is that you do 3 repetitive CT scans the patient might move in between, and then you can't register anymore, so it's always a mess. Yeah. So with photon counting, you could now imagine that you improve this. But first, let's look at some of the typical cysts or lesions that you would see. So a cyst is something non-pathological. It should not show a take-up of contrast agent in the early phase and also not in the portal venous phase. You have something that's called hemangioma that actually presents with an iris-like filling where the contrast agent comes in from the outer part, which is increasing from the arterial to portal venous phase. Metastasis would show with a rim-like pattern at the edge, and the HCC, it's a cancer. Hepatocellular carcinoma would present with a very high take-up initially and then a fast washout in the portal venous phase. So what you could do now in a clinical scan is to devise the following protocol. You inject contrast agent 1, you wait, then you inject 2, you wait a bit more, and then do a spectral CT case where the first one has already gone in the portal venous phase, about 70-80 seconds typically. The arterial scan, a few seconds, is in the arterial phase, and you do a one-shot spectral CT scan. And that would allow you to separate this contrast agent from that one, and also provide you a native image in one go and perfectly registered. Yeah, unfortunately, this is not yet done on patients because the FDA is not so happy to inject iodine and gadolinium at the same time for now, but you can do simulations, and this is an in silicon experiment where in a real CT scan these lesions have been added. So a cyst would show up in the conventional image like this. It would not show up with enhancing image in the iodine, in the arterial phase, and also not in the gadolinium portal venous phase. But you see that the liver parenchyma would enhance in the portal venous phase and the aorta in the arterial phase. So that would be really cool to separate this. That would be the signature of these hemangiomas. So you see filling from the iris-like filling, which is going in slowly from the arterial to the portal venous phase. This here would be the metastasis with this rim-like behavior that I showed before. And this is the HCC, where you would have a relatively fast take-up here and then a relatively fast washout phenomena in the portal venous phase. So presently, people are working on rabbit models to simulate that. This is one of the first scans actually done at the Philips system in Lyon, showing that at least in principle it works. So this little rabbit has been taken and got a gadolinium injection, a little later iodine injection, spectral CT scan. And this now shows the separation into gadolinium, where you see actually the gadolinium was here for the arterial phase, so you see a signal in the aorta, and a little later the iodine for the whole parenchyma. But that was not yet with the tumors and so on, but the next step would be to do animal experiments and figure out if that actually works. But I think it is actually quite an interesting opportunity that solves some of the problems. You could also think about using unconventional contrast agents. If you look here, if you look at different time points here, in such a separated gadolinium image, you would see the slow washout or the take-up and washout phenomena. But if you look at a different contrast agents, for example, gold nanoparticles, which have a completely different pharmacology, which would actually slowly accumulate and then actually stay in the organism for much longer, you could also do more time-dependent studies on the different pharmacological take-ups of the different contrast agents. Again, also this is experimental because approval of contrast agents is not simple, but once the technology becomes available, I think also the pharmaceutical companies might step on that and go in there. Okay, this was now playing with the potential of having different contrast agents and being able to separate this with photon counting. The second potential that I touched upon, the second advantage is the high resolution that photon counting detectors intrinsically deliver. Also, this has been tested in the various preclinical systems. That's a resolution chart, a test phantom, an image, here imaged on the Philips system in Lyon. This here on the left is a normal state-of-the-art clinical CT system, and here on the right is the photon counting CT prototype. And you see, you can actually resolve down to the 12.5 line pairs per centimeters, and this is actually quite interesting. The clinical case where that actually might be really helpful and cool is something everybody talks about is low-dose CT screening of the lung cancer screening, where you would actually like to see different parts in the lung, and in particular small lesions with irregularities very nicely. And this is a demonstration scan of a lung that was 3D printed as an example. And you see here, this is the binary image of the phantom, and this is the normal clinical scan at the best state of the art. This is in high resolution mode in the best state of the art system. And this now would be the same phantom scanned in the photon counting system. And you see what you have seen in the resolution chart before. This also translates to the phantom. You get a little more clarity on these images here. That also translates to patient. This, for example, is a very recent publication on the Siemens prototype, and you see this is a little lesion in the lung. It's actually a patient here, which is a little blurry in the conventional system here on the left, and actually much better delineated in the photon counting system here on the right. That is another scan done on patients also on the Siemens system, and that's quite interesting. It's a 81-year-old woman that came in with a potential diagnosis of some airway bleeding, and there you always have to look very carefully at the fourth or third order bronchial airways and see if the walls present some thickening, because that would be a sign of potential bleeding. And you see in the conventional energy integrating mode, so that's the conventional detector in this system, you see quite a bit of blur here, whereas the high resolution photon counting, this is their abbreviation for the photon counting detector, actually presents with quite some more resolution in this scan. So I think for lung imaging in particular, photon counting technology might be actually an interesting future venture to exploit this high resolution capabilities. Okay, high resolution obviously might also make sense in things like coronary arteries or stent placements. This is a simple experiment done and actually shown 2 years ago already on the Siemens system here with the energy integrating flash device, the force, and then the photon counting detectors. And you see that with the photon counting detectors, if you push them, you actually get much more resolution here, and that is kind of really helpful. Yeah, the last thing, the last advantage I mentioned before was the story that you had no noise in these images, in the photon counting detector images, and that would translate to dose reduction. There have also just been a few cases that are published and also shown in the science sessions here at the RSNA, and one I brought here for you. It's just appeared 2 weeks ago in Investigative Radiology. It's again on the Siemens system. And this is for clinical applications to image the head, and more particular the sinus or the temporal bone. So these are special high resolution protocols where you look at the nasal airways or the bones, the small anatomical features of the bones in the hearing system. And you see that this here on the left is a normal clinical routine scan done at 120 kV with a dose of 13.6 milligray. And you actually get, when you use the photon counting detector, already a quite substantial dose reduction here. And you can also see that in the mean values of the noise here are even lower. So and that at a higher resolution. So in this particular application for high resolution imaging features of the head, I think photon counting immediately has an advantage. Really drastic is the advantage when you consider scans done with this UHR. UHR means ultra high resolution. This is actually a mechanical comp that is inserted in front of the detector that's blocking half of the detector pixels to make high resolution images possible. But the downside here is no free lunch, so you get to 66 milligray in the present clinical routine. And that's of course not nice. Yeah, you have to image these temporal bones for certain reasons. If there's inflammation or so, you also need this high resolution when you place hearing aids in cochlear implants. There, it's absolutely mandatory. No way around that. Yeah. So when you use the photon counting, you see that actually you immediately can exploit the fact that it offers this high resolution, provided the X-ray tube is actually has a small focal spot size. In this case, you go down to 10 milligray, and yeah, I have 85% lower dose, which is substantial, I think. Okay, so I'm more or less already done. Beyond the present large-scale full-body systems, there's of course a lot to explore off the beaten track. One thing might be the now it fails. So one thing might be the breast CT system that has been recently shown here at the RSNA, and that's also using photon counting detectors to eventually deliver very high resolution 3D imaging of microcalcifications. This is presently still in exploration phase, but that's something that was enabled by these low dose and also low noise detectors, I think. And the other thing that is very interesting, that is just in a booth over there, now it's actually failing, is this EOS system that came out, or that was modified with these photon counting detectors, where you actually get a really exquisite resolution for musculoskeletal imaging in particular, and I think this is really nice. Yeah, with that, I hope you got a little overview of the clinical applications of present-day systems and what you could do with photon counting. Just as a wrap-up, somebody needs to get me some batteries at some point. Yeah, take-home messages. Dual energy CT helps in the cases I've shown in neuroradiology, oncology, abdominal imaging. There was this case with this differentiation of iodine and density that was solved with the virtual non-contrast and iodine basis material decomposition. Mono E low and high, low good for getting better lesion detection, high for avoiding artifacts. Effective C might help to differentiate different parts in the human body. So this is actually used daily practice today. Dual energy, we have it. God, I'm sorry. This is a mess here. Okay, and the second part, photon counting, we had these three advantages. Remember, high resolution, essentially more energy bins, and potentially lower noise, so low dose then. And I showed you, for example, these multi-phase scans where you could do one scan at the same time and then differentiate the different contrast agents. High resolution for stents or for the temporal bone imaging that we also saw presented a very, very good dose reduction. And this last case of the beaten track breast CT 3D system might actually eventually turn out to be of very high clinical value compared to the present 2D or tomosynthesis approaches. Yeah, with that, thank you very much. And now I need some new batteries. Thank you.